Bueno, vamos a iniciar este increíble webinar que créanme que estamos súper emocionados por la persona que tenemos aquí invitada el día de hoy. Les voy a presentar nada más y nada menos que al doctor Salman Pervaiz. Él, bueno, tiene doctorado, es manager en perfusión de su hospital el Instituto de Cleveland Clinic en Abu Dhabi, de Emiratos Árabes Unidos. Él también es co-chair del comité de SWAAC de ELSO, de toda esta parte de tecnología de SWAAC ELSO. Y también, bueno, ha hecho muchísima investigación, es un investigador también honorario de la Universidad de Bristol de United Kingdom, de por allá. Y también Salman, bueno, tiene 25 años de experiencia ya en toda esta área de perfusión. Actualmente ya se está dedicando bastante a la investigación también. Ha hecho más de 43 publicaciones también. Y bueno, hoy nos va a hablar de un tema súper interesante que es justamente esta transición de la anticoagulación de SECA ECMO, ¿no? Que creemos que es un tema sumamente interesante, un tema sumamente discutido actualmente. Y bueno, sabemos que la anticoagulación tiene unos retos impresionantes. Entonces, el objetivo de este webinar es para que ustedes se empapen de las nuevas perspectivas clínicas y los retos actuales que tenemos en esta área. Entonces, les agradecemos mucho por estar aquí el día de hoy. Yo sé que es un lindo sábado a las 11 de la mañana en Ciudad de México y sus respectivos países, pero bueno, creo que es un gran día para aprender bastante de Salman. Así que, sin más, voy a darle la palabra a Salman. Thank you very much, friend, for being here. Salman, it's a really great honor to have you to share your knowledge in our community in Latin America. And this is really a great opportunity for us to learn of your last investigation. Thank you very much.
Hello,
Perfect.
guys. This is Salman, and thank you for a nice introduction and having me here, Jennifer. And It's been an honor to do a talk on this lecture. I think it's a very interesting topic. Recently, I figured out that there are not many guidelines written about this, and I thought like investigating it further. Uh, so, and then I was chatting with Jennifer, and she said that why not do a talk on this? And I thought like it'll be a good opportunity to discuss with the peers and other same relevant profession people, so we can actually get their perspective and see what they think about this. As we are thinking, if we are at the same level or we are thinking differently. So I think it's like a brainstorming kind of a session. We'll be giving some of the polls during this. Some of the videos have been prepared so you can actually see different perspective in OR versus ICU settings, and looking at different kind of you know perspective in terms of dosing of ECMO for anticoagulation purposes while you're converting from a bypass to ECMO or converting from ECMO to bypass. So this is the topic we're going to do today. Before we actually move forward, I would like to see who are the audience are and who are actually participating today in this webinar. Yes, I can see the results, and it's good to see that most of us are perfusionists here, which is good to see. About 39% of the perfusion is ECMO specialist. And it's a good mix and match from all over. And I think thank you for sharing and attending this poll. And you'll be receiving more during the talk. So thank you very much. So let's begin with the talk. So obviously, my introduction has already been done, and thank you for having me here today. So basically, what we are talking about here is a transition from cardiopulmonary bypass to ECMO, and it's obviously a critical phase when we do that, often necessary in post-cardiotomy shock or other severe cardiac conditions. Optimal anticoagulation reversal strategy remains poorly defined. I have looked at different literature and I did not find many guidelines on this topic. So it would have been nice to show you the transition itself in a video, that how we move from cardiopulmonary bypass to ECMO, or a simulation video would have been nice to see what strategies happen, what is the thought process, what is the multidisciplinary decision making while we're doing that, how early or how late this decision can make an impact on a patient's outcome. But obviously, I will try my best to show you different videos and trying to make the perspective so you can see what the difference is. Because I'm not sure what you are different from different backgrounds, but not sure which at what stage you are at your career. So I actually prepared this presentation from basic level to somehow expert level, so everybody is included in this webinar and what I'm going to present today. So you could see both pictures in this slide. On top, you can see the ECMO running, and on the bottom is a picture of a heart-lung machine running a cardiopulmonary bypass, just to give a perspective. So just to give a basic idea and a difference between the ECMO and the cardiopulmonary bypass, I've actually prepared one video which actually shows you what the cardiopulmonary bypass is. So from a cardiopulmonary bypass perspective, you could see the difference here is very clear. So if you look at this line, normally you would see there's an arterial and venous line coming in here. So cardiopulmonary bypass basically is going to take over the function of the cardiac heart and the lungs. Uh, and so it's gonna produce the cardiac output and also give the oxygenation to the patient at the same time. So like we do in our ECMO, VA ECMO is the same kind of modality. What happens here, and the difference is that you can see this venous line coming from the top into this reservoir. That means in an ECMO, you would not see this reservoir. It's actually directly attached to the pump, centrifugal pump, and it takes from the patient and centrifuges it and goes back into the oxygenator and goes back into the patient. Here in cardiopulmonary bypass, it comes from the patient. Let's say in this case, it's coming from a venous cannula, which is actually a two-stage venous cannula in the RA. It's happening through siphoning. So you could see there's no pump attached because of the height of the patient on the table and the height of the oxygenator. It's siphoning from the table to the reservoir. So blood comes from here, goes into this oxygenator, which is a reservoir part of the oxygenator, goes back in here. There's a centrifugal pump right here when I play the video. It goes from here and it goes into the oxygenator. You could see this green line like in our ECMO. It's actually diffusion is taking place. So from high to low, oxygen is diffusing into the blood, CO2 is coming out, and it's actually going back into the patient, ascending aorta, and this is how it's taking place. And it's bypass, it's a cardiopulmonary bypass setup. So if I play the video, you can see it. And you are achieving about 3.34 cardiac output in terms of flow. I'll play a couple of times. It's
A
a
little
bit
bit
fast.
super low, please. Sorry.
Okay, so just play one more time and you can see that it's coming from the venous, it's going into the reservoir, then the centrifugal pump, then it goes back into the oxygenator and then goes back into the patient. So this picture actually shows you the same thing, the difference between the cardiopulmonary bypass and the ECMO. So if you look at looking at this line, which is coming from, let's say this is coming from the patient, it's a venous line. Let's say access line coming from a vein. This reservoir is actually isolated by these clamps. So if the drainage is coming from here, goes back from here, goes into the pump, oxygenator, and goes back into the patient. So this is your, let's say, a VA setting. So venous cannula, drainage, pump, oxygenated, and then go back into the patient's artery, let's say a femoral artery. If we clamp these two lines here, the bypass lines, and open these clamps, that means the volume is coming from, let's say, from the vein, goes into this reservoir, then goes to the pump, then goes to the oxygenator, and then goes back into the patient. So basically, that becomes your bypass circuit. So we call this as a hybrid circuit. We use that in our lung transplantation setup. So basically, you will run the patient on ECMO, VA ECMO, which could be centrally or which could be peripheral ECMO. And if we need to, during the procedure, go back into the full bypass, you have a provision to go back onto the full bypass. So what you will do is that, let's say you will start with a VA ECMO, RA cannula, and aorta. So drainage from the RA returning to the aorta is coming from here, go back in there. That's your VA ECMO. Let's say during the bypass, you are not able to maintain full flow. Your lactate starts going up, or you are actually not maintaining with is causing hypovolemia. There's some lot of bleeding. is actually going, a lot of blood is going into the reservoir. Obviously, you're losing all the products. So then you will make a decision during that procedure and saying that we will be converting into the full bypass. At that point, again, comes back to our discussion point, which is anticoagulation. So what happens there? So let's say you're running on a VA ECMO. Mostly we go by in the OR setting by ACT levels. So we run our VA ECMO intraoperatively between the number of ACT of 220 or above. So we run ACT above 220. Basically, that's our target number that we run the VA ECMO on in the OR. Let's say we will have to convert it to the bypass, then we will give extra heparin to accommodate that. For full bypass, our recommendation is to go over 480 to go on a full bypass. And at that time, we will bypass. We'll take this clamp off. The pump will be running full bypass, and we will close that loop, which was creating an ECMO. So let me play this video, which will explain you a little bit more. So you could see that it's a VA ECMO at the moment. So the venous line is there. It's coming from the back of this back of this reservoir. The reservoir is clear. So basically, this reservoir has been isolated. One clamp here, one clamp there. So no blood is going through this. So blood is coming through here to the centrifugal pump, going back into this. You could see this blue oxygenator at the back, which is our PLS long-term oxygenator. So he actually goes from here, goes into the ECMO oxygenator, get oxygenated, and goes back into the patient. So as I said before, if we have to convert, then obviously the discussion will take place at the time that how much heparin we need to give. We are on ECMO already. So what we will do, give extra dose of heparin. Let's say we have 220 at the time. We need to achieve 480. So the anesthetist will calculate. Normally we calculate on the depending on 400 units per kg, but obviously the ACT is already 220. That means there's some anticoagulation already there. So anesthetist will decide about what percentage of or what dose of heparin at that time needs to be given to achieve the full ACTs. Once that is given, we'll do the ACT, and if it's over 480, we will start converting into the full bypass. Why do we need actually a 480 during cardiopulmonary bypass? For the nurses, the perfusionists will already know why we need it, because it's a bigger surface area, more inflammatory response can come in and kick in, and obviously that's the recommended ACD levels to prevent any clots into the reservoir or in any part of this oxygenator or the circuit. So I think this is a time for poll before we go into from cardiopulmonary bypass to ECMO and discuss more anticoagulation levels. So if you take part into this survey, it will be very nice. I'm trying to look for the English version of the survey, the poll question. So in your current practice, how often do you encounter the need to convert from CPB to ECMO during or after cardiac surgery? The options are rarely, occasionally, or frequently, or never. So it depends, what you guys do in your own centers and how often do you see this kind of scenario happening in your daily practices. So our results have come up. So basically, about 44% of the participants have said that it's actually they see it very rarely, and about 22% see about occasionally from 1 to 5 per year, and 70% actually see that more frequently. So it's actually a good mix to see, but you guys are seeing this happening, so it's actually good and very relevant. So moving on to from cardiopulmonary bypass to ECMO, the definition is very clear. We are converting and transitioning from a full bypass circuit to an ECMO circuit. Purpose is very clear: maintain circulatory or respiratory support when weaning from CPB fails, and common indications involves persistent low cardiac output, severe respiratory failure, refractory cardiogenic shock, intraoperative myocardial dysfunction, which can happen during cardiac surgery. Okay, what is the rationale for when we start converting from CPB to ECMO? In this scenario, when we convert from CPB to ECMO, it's actually most of the time it's actually to improve chances of survival. To be honest, is the bottom one. And in patients which are unable to wean off, because we are trying so many times to come off bypass with high inotropic support been running, and it's still not coming off. And then your other option is actually to go on a depending on the situation, patient might already have a IABP or not IABP, and then will be the second step to go into the bypass itself. Yeah, I mean to ECMO itself. So timing is very, very important in decision making. So as I said before, it could be early means on time, I mean, or late when after failing many times of attempt of coming off bypass with high inotropic support, keeping the heart empty or full versus empty versus full, looking at the TOE, how the function is doing. So the decision is very important, and when you make that decision is also very important, because if you prolong the bypass to avoid any circulatory support, then obviously you are making chances for that patient survival lesser and lesser, because more you stay on pump, the the outcomes will be worst. So predictors of failure to wean are mostly you could see uh, you are not able to maintain good mean pressures with a very high support. Also, the lactate levels are poor. You can see it while even on pump. A cardiopulmonary bypass, poor mixed venous saturation can be seen, and more importantly, persistent ventricular dysfunction on TEE can also be seen. So these can be predictors for you to indicate that, okay, we are going to need some sort of circulatory support at this time. So pre-conversation, conversion consideration, what do you consider? Obviously, multidisciplinary discussion should take place right there and then, uh, while patient is on the table and people are discussing. Then obviously, cannula strategy is also very important, and the anticoagulation strategy should also be discussed at that time when you're actually making that decision, because you may be on centrally most of the time for cardiopulmonary bypass, but you may want to convert it to a FEM VA ECMO uh, as a conversion strategy, and to be able to close the chest of the patient. So if you are centrally open, then obviously the chest will not be fully closed, or you have to tunnel the cannulas, which will be a different ask for the surgeon at that time. Again, coming back to the same point, I was looking at this anticoagulation strategy and different practices before as well into another survey which I conducted, and it was run for 3 months, and different platforms were used. Obviously, same kind of peers were participated in this survey, and obviously, and we got some results out of it. From that survey, I picked up 4 questions which actually are quite relevant to the talk today, and it's actually good to see that what you guys do in terms of those questions. So we could get some answers from the audience here. So you could see that in my survey, it's actually 447 respondents were there, and at least 45% of the ones are using heparin in the prime. So reason why I'm saying this is a good question to ask in this, why this is all not been discussed in a literature, basically, if you look at it, that when you actually, let's say, converting from a CPB to an ECMO circuit, your ECMO circuit already have 5,000 or 10,000 or 2,000 heparin inside it. That also is a factor to be considered while actually reversing an heparin, let's say, or patient is bleeding for sake. So all these factors should be included in that discussion and consensus, or any research needs to be done to include all these factors while making all these decisions and making these guidelines. So we'll wait for the poll here to see what results we are going to get here. So the results are here. Obviously, again, it's not a surprise. Obviously, around 74%. Sorry, this is coming in. So they said they actually put heparin into the ECMO circuit, which is C means obviously yes, I think. So 74% of you guys are actually putting heparin into the priming circuit. We don't actually put any heparin in our circuit. All the circuits are heparin coated, and we don't actually have a practice to put. We do put heparin into the cardiopulmonary bypass circuit, but we do not actually put heparin into the ECMO circuit. That's our practice. Okay, moving on to the next question. So how much heparin do you administer before commencing on ECMO? This is a regular question. Like, let's say you do a normal ECMO. What is your, how much bolus doses you actually give to the patient before cannulating or before inserting the cannula? Or let's say you put the wires in and now you're actually going to give any heparin. So according to my results here, out of 381 respondents, uh, about it's actually a range between 2,000 to 3,000 units are common uh, doses, starting doses before initiation of ECMO. So let's see what you guys are actually do in your practice. That's amazing. So you could see that about 39% here are also using 2,000, and it's between 2,000 and 3,000. And look, it's actually quite interesting that 44% actually don't actually put any heparin into the ECMO. That's what our practices are. So it's actually good to see your practices as well. Thank you. Okay, moving on to the next one. So what is your preferred method of monitoring? So it's actually an interesting question because we actually in OR, what we do is actually we measure through ACT. So that's our first instant results. What we look at, if we are running an ECMO inside an OR, it will be above between 180 to 220, which is an ELSO standard of anticoagulation level inside the OR. That's what we use. Other than that, in ICU for bedside management, obviously the results take time. So we do have actually a facility of TEG, APTT, and obviously anti-10A levels. And sometimes some physician, depending on they use combination of these to make decisions on the amount of anticoagulation or for sake no anticoagulation requires depending on the patient. So obviously this is also a very critical point to see. Okay, so this is so 37% are actually using ACT again, which is quite normal. That's worldwide practice actually, especially in OR. They actually use, and it's actually a good handy result. It actually comes very straight away. It comes straight to you. But obviously, when you're doing a bedside management, I think more reliable results are actually like anti-10A, APTT levels, and or a combination of that. Good to see that. Okay, the last question for the survey, which I picked up for this, is like when you actually have a heparin-induced thrombocytopenic patient, what is your alternative to unfractioned heparin? We normally use for bivalirudin for that, which is heavily used. Even we get some patients which are HIT patients, and they come to OR for a cardiopulmonary bypass or a cardiac surgery operations and we have to use cardiopulmonary bypass for them, and we use bivalirudin. One of the experience what we have is actually because there is no reversal dose for bivalirudin because they are the direct thrombin inhibitors. You could be in the OR for a long time to sort out that bleeding because the bivalirudin effect has to wear out on its own, and it could take ages. So it's like I had an experience of doing some of these cases on cardiopulmonary bypass, and actually they take quite long to wear out. So the results are bivalirudin is 55%. I think it's very good to see the uniformity. It's actually quite uniform. Many people actually use worldwide bivalirudin more than argatroban or any others. So thank you for taking part in this survey. I think it actually gives you some perspective as well to see what others in different units are actually doing. And you could see that your practice is actually matching the others when you look at anticoagulation levels and the alternative to that. So let's come back to our point. Why are we actually talking about this topic today is actually because there are so many under discussed or under researched points into anticoagulation when it comes to conversion, transitions uh, from ECMO to bypass, bypass to ECMO, regarding reversal. There are challenges immediate to ECMO support, post-op cabbage, what heparin levels you should be running at because patient is after cardiac surgery, what should be the management protocol into the ICU. Obviously, looking at circuit thrombosis in your mind, obviously bleeding, should we reverse the protamine partially straight after while patient is on ECMO, or should we leave it and let it wear out itself? Or is it going to cause a lot of transfusion because the heparin is anticoagulation is on a full level according to cardiopulmonary bypass, and you just convert it to an ECMO. So there are no consensus or guidelines, not many, which I can see, and I think practice varies very, very much, and it's everywhere. People are doing different things. So when I looked at the literature, I found this paper very interesting. They actually presented six pediatric post-cardiotomy patient and with refractory to surgical site bleedings. And they are trying to show in this paper is actually in a short summary that the bleeding itself is not a contraindication for going on an ECMO. So these patients were bleeding, and obviously it's a it's a it's a relative contraindication, but not absolute. So they had a success rate of about 6 out of 5 patients survived. So what they done is actually as soon as they converted, uh, they kept the ACT levels between 140 to 180, and APT level normally with you do about 60 to 90, which is they kept it 50 to 70. Monitoring wise, they use ACT, and one of the patient they actually did not actually start any heparin uh, until 32 hours. So you could see that different practices can happen and different modality for different kind of problem they are using, and their different strategy they are using for these. So currently, what evidence says is actually quite very diverse. Again, some center omit anticoagulation completely when they actually transit from cardiopulmonary bypass to ECMO. Some actually reverse the protamine, depending on the dose, how much they give. Some incidents have been reported of clogging the actual ECMOs because once you give protamine and it actually suddenly delta P levels go up, and obviously it stops the your ECMO circuit, it clogs it, and you may have to put another one in, or patient might not survive. So there have been incidences in the reported in the world that this can have that detrimental effect on the ECMO. So this is a very critical point which needs to be looked at. Yeah, you cannot have a overly bleeding patient, or you cannot have practice where actually the whole circuit gets thrombosed. So I'll give you two. I'm going to present here two scenarios. One is from ECMO to cardiopulmonary bypass, and also other one from cardiopulmonary bypass to ECMO. And I will show you how different little effects actually, which are not discussed, can affect the patient outcomes or patient safety. So we present the first scenario from ECMO to cardiopulmonary bypass. So this is a 62 years old male, post-infarct, papillary muscle rupture with MRR placed on a peripheral ECMO, which is for 12 hours ago. And the cannulas which were used are uh, Just one second. So the cannulas which are used are 25 multi-stage venous cannula, which is a regular venous cannula, which is a kind of a standard for adult, and 17 French right femoral arterial cannula was used for that ECMO with a 6 French distal limb perfusion cannula. So ECMO support on arrival to OR, flow were 3.8 liter per minute. Sweep was 2, FiO2 was 1, and MAP was 70, and very low dose of norepinephrine. So patient is quite stable on ECMO. The only thing you look at here is the hemoglobin is about 9.6, which can be diluted when they actually go on pump because the circuit needs to be primed with blood. So that's what they have done. So in a preparation, they have actually, here it says that it primed with crystalloid plus RBCs. So team briefing happens. Anesthesia, perfusionist, ECMO specialist, all involved, do the briefing, what would be the strategy, what monitoring we're going to be using, all the monitorings which we'll be using, they were using are bilateral radial, right femoral arterial, CVC obviously, and cerebral oximetry, and obviously TE to look at the heart function. From a perfusion setup wise, as I mentioned, priming both with crystalloid and RBCs, and obviously blood products and everything was ready for this procedure. So patient's ACT was before coming in was 200, and unfractioned infusion will not be stopped until the full dose of heparin was given to the patient, and they chose to give 350 units per kg. ACT after 3 minutes come back as 370. As I mentioned before, we need at minimum of 480 ACT to commence the full bypass. So patient is still on ECMO, ACT come back 370. So there are 3 video clips I'm going to play here, and you could see that there are factors of safety, factors of anticoagulation dosing, factors of how you react in this sort of situation, and the decision making. All these things will be displayed here. This patient is ready to go on bypass from an ECMO, and this is the perfusionist you are seeing in the picture and the video. And the conversation, first video, we have a conversation between perfusionist and the surgeon. If you don't hear the quality of the if the quality of the voice is not good, then I will explain further.
Very talented. Can you go on bypass, please? Hello. We waited 2 hours this morning already. Go on bypass, please. Hello, Joe. Just go on bypass, please. Okay, go on.
So if the quality was not good, I can explain what has happened here is perfusionist is saying that the ACT is 370, and the surgeon is saying we have wasted quite a lot of time before, and let's go on bypass. And perfusionist is trying to make a comment saying that shall we go on bypass? It's a bit low. So that's what happened there. And then ultimately he is trying to be going on pump because the surgeon has told him to do that. In second video, you will hear a conversation between the perfusionist, the surgeon, and then the anesthetist.
ACT top 370. Oh, what do you think? Shall we get some more? I've got 10,000 prime, which will be fine. If you're happy to ask, just go on bypass. Thank you. Yeah, I'm happy. Let's go on.
So this is a 3-way conversation. What happens? Perfusionists say the same thing. 370 ACT, shall we convert from ECMO to bypass, or can we go on pump fully? And the surgeon says that, are you happy? But the anesthetist said that, shall we give 10,000 more heparin to bring the ACT above 480? But the perfusionist has said he's got 10,000 heparin in the prime. So basically, that's again another perspective which needs to be seen when you're converting from one to another. That's another factor needs to be incorporated into the policies if we make in future that, some of the cardiopulmonary bypass practices are different. Some people use 5,000, some people use 10,000, some people use even less or more. So these are the factors also needs to be included. So in this case, perfusionist said he has enough in the priming and it should be adequate when we go on pump. So basically, without monitoring, he is happy to go on. So which is not the right thing to do, because you could easily end up having this situation where your reservoir is clotted or an oxygenator is clotted of cardiopulmonary bypass because you're off ECMO and now on cardiopulmonary bypass, but with a very low ACT. The final video is actually going to show that what is the right thing to do and what needs to be done.
He's stopped at 370. Can we give 10,000 extra heparin, please?
Sure, I think it's a good idea. I'll give 10,000.
Thank you.
All right, let me know when you guys have this.
Okay, we'll recheck it once the heparin's in.
Okay.
So in the final video, obviously everybody collaborated. He said, we'll give 10,000. Surgeon said, there's no rush, wait for it, do the monitoring, get the ACT above 480, and then go on full bypass. Reason to mention why the ACT coming back at 370, even giving high doses of ACT, of heparin, is because patient, most of the time when come from the ICU to the OR, they are actually on heparin or on anticoagulation. So the patient could easily be heparin resistant and have low AT levels. So it's actually good to check these things right rather than jumping into all these scenarios without monitoring. So monitoring is very important of the ACT, and also the 2-3 factors we have seen here: priming, having heparin, patient could be heparin resistant. Monitoring is very important. Conversation is very important while you're converting from one modality to another. Okay, so let's say that ACT in the first go came back as normal. Forget about the heparin resistance. Let's carry on with the normal scenario. So the ACT after 3 minutes, giving after 350 units per kg, was 486. No top-up was required. No extra heparin was given. Perfusionist confirms he's ready, and AT supplementation is not needed. Conversion step: ECMO flow maintains at 3.8 liter with ACT above 480. Venous and arterial lines from the ECMO are clamped, disconnected, connected to the ECMO circuit, to the bypass circuit, and with the go on bypass. And with the ECMO circuit is created a closed loop with a connector, so it can be used afterwards if it's required post cardiac surgery. So you could use still the same circuit after the bypass is if you don't if the bypass cannot be weaned. So safe on ECMO, and ECMO on standby, ready for rapid reconnection if required after the valve surgery. So that's the first part done, which is a cabbage, from ECMO to cardiopulmonary bypass. Now, if we look at from cardiopulmonary bypass to ECMO, let's get into this scenario. So the patient is a 60 years old male, urgent triple vessel disease, cabbage EF of 20%, and already has an EIA-BP inserted in the patient. So intraoperatively, cabbage, cardiopulmonary bypass via aorta plus RA cannulation, ACT is greater than 480. Grafts completed, rewarming to normothermia, and is failing the weaning process while coming off bypass. So severe biventricular dysfunction, MAP is less than 50, SVO2 is down, lactate is high while still on cardiopulmonary bypass despite maximum inotropic support and already an IABP support available to the patient. So decision was peripheral VA ECMO before discontinuing CPB. So the conversion steps are, it was decided that it will be FEM VA ECMO. We need to go back on rather than central, so they can easily close the chest, which will reduce the bleeding, chances of bleeding, hematoma, or other issues like infections, so they can close the chest. So again, the regular cannulas were put in, 25 French, 17 French, 25 venous femoral, 17 arterial femoral with distal perfusion, and they were inserted at the moment. So the ACT is not an issue because your ACT is already 480. So gradually, heart has been filled to come off from the cardiopulmonary bypass side and slowly initiate the ECMO side. And once we are fully cranked up to the ECMO flows, which are 3.4 liters, then we come off bypass. and remove the cannulas from the aortic and femoral, aortic and venous side centrally. So here, let's say this patient, as soon as you come off bypass, patient ACT is still greater than 480. In this case, it was 650, let's say. And there is a dilemma here that whether patient is bleeding heavily and all the volume is actually going back into because you're completely disconnected from the pump, so you cannot actually give volume back to the patient from that side. So it's actually going all into the into the cell saver, and actually where you can only save the RBCs and the rest of the products are getting depleted. And and it's like a circle which you're going in this patient, and that at this time, what would you think as a multidisciplinary team? Should we reverse the protamine? How much protamine should we give? If we give more, then it might clog the circuit. What should be the speed of the how slowly or how fast should we give the protamine? So all these questions come up into the mind when you're actually doing all of this. If you're trying to reverse, if the patient is stable and is and not that much of a bleeding, and bleeding can be many reasons, depleting platelets, being on pump for a long time, and all those sort of things. Or patient could be bleeding for different sites. It could be surgical bleeding, could be pharmacological bleeding. So let's say this patient is bleeding heavily and you are actually at a decision to give some protamine to the patient. What is the protocol? What is the policy? What is the guidelines available so you can actually give this to the patient? We experienced this in a couple of patients, and let's say one of the patient, when we come off, it was the main factor is to check the ACT at that time when you're actually on ECMO, because ACT might have already dropped. So let's say ACT was 480 while you were on pump, or 600 while you're on ECMO. After some time, it may have been 350, 380. So you don't want to overdose the protamine. Let's say your protamine dose is 1 ratio to 1.5 ratio when you're actually giving back the reverse. But again, you need to know that we already know that we need to come back to 180 to 220. We don't need to fully reverse it. So in those patients, one of the patient was used only, that full dose was about 300 milligrams. So it was only 50 milligram was given, and it was given in every 5 minutes interval on a small doses. And when we check the ACT come back as 190. So only 50 was given, and actually the results were as adequate as it was required. Again, this can be one scenario, but the reason to mention all these things and different perspectives are because the whole point is to come to a point where actually there are some sort of guidelines when these conversions are happening, and where all the factors are actually incorporated while thinking. So we thought about it, and I wrote a letter to an editor to the Annals of Thoracic Surgery recently, and asking the same kind of brainstorming questions, that what should be the best policy, or what should be the best strategy, or the bigger organizations like ELSO, like STS, EX, gather together to get this consensus or a policy to be made on this quite critical topic. So we wrote that, and obviously got published. And this is one of the flow chart outlining the key consideration and decision-making pathways involved in transitioning from CPB to ECMO. It's like a structured approach to look at different things. It's not a right answer, but it's actually things to be pointed out that can be looked at while making a decision, while dealing with these patients or these kind of transitions. So you could see a little bit of detail, let's say ECMO circuit, which is going to be used. One I already mentioned, having heparin already in the prime of that circuit, could be coated versus non-coated, whether you need more anticoagulation on coated or not non-coated. So whether does it actually make any difference, coated or non-coated, in terms of anticoagulation? Practically, again, reversing protamine could be half dose. Should we give quickly? Should we give one dose, or full dose slowly in multiple times? Same as looking at reversal of anticoagulation from direct thrombin inhibitors. Looking at there's no There's no reversal, obviously. So looking at kidney clearance, liver clearance, all these factors should be incorporated in that. What we are proposing, like a consensus or guidelines, should be created. Again, obviously, the role of anticoagulation monitoring systems like ACTs, TAG, scrotum, they also need to be considered. So all these factors, just to put it out there to see that these factors needs to be included in some sort of a policy or guidelines in future. So what are the proposed research areas in this thing? Define safe protamine to heparin dosing ratios, comparing full versus partial, evaluate quoted ECMO circuit, establish monitoring algorithms, as I mentioned, multi-center data collection for guidelines. So suggested pathway is actually initiate consensus. That's what I think should happen, building consensus building by societies and ECMO consortia. Design could be multi-center prospective studies, integrate findings into evidence-based protocols, and obviously the goal is to reduce complications and improve ECMO outcomes and improve standardized practices. So in conclusion, anticoagulation reversal during CPB to ECMO is under-researched. That's what we believe. Absence of guidelines leads to variability and risk, and coordinated research is essential to establish safe practices. Before we finish our talk, I have this small video converting from a central bypass to ECMO. So it's self-explanatory what has happened. The main thing to see in this video is actually the preparation is very important. The discussion is very important. The things has to be ready when you're actually transitioning from one to another. Sometimes patients are quite very, very sick and they don't really give you that much of time. Sometimes we had, sometimes that I'm converting from a CABG to cardiopulmonary bypass to an ECMO, and then ECMO needs to be also saved to give a connector to create a loop. So if you need it afterwards, that will also be available. And obviously, some people have practice of putting some heparin into that circuit as well and run some sort of FiO2 levels as well, oxygen levels to that circuit to keep it patent if we need it afterwards. So that's about that. Just a little demo of how you convert and how much preparation is important and anticoagulation levels are important before you convert to one and another. So based on today's discussion, this is the one, right?
Yes.
Okay. So obviously, first one is yes in most cases. Is that correct? 14%?
Correct.
And so basically this one is actually when planning a CPB to ECMO transition, which factor most influences your anticoagulation strategy? So 55% is due to risk of bleeding. That will influence this anticoagulation strategy. 36% for thrombosis. Institutional is number 3. The surgeon's preference 0. I thought this will be the highest.
Yes, totally, friend.
Are we talking the truth? So I think this ends my presentation here. And these are some of the references. And thank you very much for having me today. It's been a pleasure. I don't know whether I was talking too fast or slow for the translation, but I apologize for that.
Thank you very much, friend. Well, we are going to continue with some questions that we have in the audience. So thank you very much for your excellent participation. And well, we have some questions about the protamine. One is about, okay, which is the relationship between heparin and protamine doses for convert SEC to ECMO? This is one.
So what's the question? Sorry, say it again.
Don't worry. What is the relationship between heparin and protamine to convert SEC to ECMO?
To convert from CPB to ECMO.
Sorry, CBP. Yes, to ECMO.
Okay. I was so what is the doses references basically? So this is what we're trying to find out. Basically, there is no set doses. Like when we're converting from CPB to an ECMO, obviously the set dose of protamine they're talking about, right? So I have a couple of patients' experiences. What we have done, as I said, one of the patient was like the ACT came back as 338. Once we go on to an ECMO, patient was heavily bleeding, but we have to convert it. We have to give some protamine while on ECMO, but people would be skeptical, like they will be afraid to give a full dose of protamine. It might clog the circuit and it could affect the patient very much. Some people actually leave it most of the time to wear it out after some time, so it will go down automatically. But in that time, if the patient is so much bleeding, it will lose all the volume into the cell saver or outside suction. And because there's no way to return from your side, either to send it to the cell saver and then transfer, self save and obviously lose all the products. So I think there is no set dose. So there's no set dose, no set kind of speed, intervals. I was even thinking that it should be given in like through a syringe pump, like slowly in that kind of things. That may have lesser effect. If you give bolus, that might clog the circuit or affect the part of the oxygenator, because you don't know, oxygenator may still be working, but obviously because of the protamine, it had clogged one of the part of the oxygenator, let's say one of the portions, which will make the efficiency down. So they are no set things. That's what we're trying to find out.
Totally.
That there should be some guidelines.
Totally. Actually, I think you answered the second question, but it's about, in your experience, which is your protocol that you use about protamine? I mean, you use reversion, partially reversion, or total reversion?
So we have done partially reversion. No, there's no need for full, because obviously you need to some sort of have anticoagulation level in the ECMO as well. So you need to reach to a 200, 220. That's your target. So obviously you don't want to reverse fully. Then it goes back to 140, 120, which is your baseline. And obviously the baseline numbers are quite important. So that's in my point of view. I think it should be partially and to see how it goes. And then obviously you can see the results first. Because if you fully reverse and then see that it's going to 140, you might have it might clog the circuit. It can easily happen. Your delta P could shoot up straight away and you will see that it's actually happening. So it's actually giving partially and then see the results. Give it slowly, see the results, I think. But again, it needs to be decided. It needs to be a consensus building kind of, it needs to happen, basically. There should be some sort of guideline into this, because I think I always say that it's under discussed, this whole topic.
I think you also answer about relationship of the third question, but I want you to share a little bit your experience on coagulation of the circuit after doing these kind of protocols. The thrombosis of the membrane or the centrifugal pump. What do you can say in your experience? How many accidents do you have about this kind of matter?
So the thing is, at the moment, we did not have any accidents according to this, but obviously we see that regularly uh, change of oxygenators in ECMO circuits. So that happens regularly. That's a normal practice. Changing an ECMO circuit is actually a normal practice now because that has to happen because over a period of time they will clog, there will be delta P will be higher, there will be platelet depletion, it will require circuit change out. And what we normally do, what our practice is actually, as soon as we change a circuit, we try to, if a circuit has been recently be put in and we actually are going to change it quickly, let's say it has been changed after 4 or 5 days, then you should actually see it, what has actually happened to it. So what we do, crack open the oxygenator and we see always all the circuit to be flushed and see where the actually clots are, whether it's in the pump or is actually in the oxygenator where they actually are, or if there are any. Sometimes it could be decision-making issue because you might be seeing there's platelet depletion, but there is no actually clots inside the oxygenator. So I think that's our regular practice. We do flush the oxy and see it.
But maybe more relationship between this conversion and the coagulation of the circuit. How many times have you experienced this?
We have not experienced any clotted oxygenator, but this is one of the things that we look at dosing. So we actually are very careful of what we reverse. So if we reverse very carefully, I think your results will be better. This is why it's so important. I think it needs to be fully researched, like a prospective study from multi-central trial, looking at what doses you give, like trying to create some sort of evidence-based guidelines. I think that's what is required because everybody is doing different things.
Totally. And I just have some question about that. What do you think that we need for have some globally standardized protocols? Because right now is more institutional stuff, also preference of the surgeons that we have discussing. So I know we need more investigations, but in your consideration, which are the key factors that we need maybe for more globally standardization, or what are the obstacles for having that?
So I don't think there are any obstructions. I think because why I would say that is because when I looked at you look at the data, looked at different studies. Even I was searching when I was doing this presentation, I thought like there will be many papers about this. Like I didn't find many. So it's all about taking the initiative. I think I looked at it. This is why I sent that letter. And I sent it to see that what the response would be because it's a bigger journal. So they would obviously have seen these kind of things coming to them. And if this was accepted, that means it actually has a value to look into it. So that gives you a little bit of positive indication that you could go further. So I may be looking at, in future, looking at developing some sort of a consensus statement like you are seeing nowadays about Delphi statements and Delphi method people are using to get the consensus, like EX guidelines, where you get different experts and get the expert opinions, do the survey, and all those sort of things can be done, rather than even doing a prospective study. You can actually have a consensus building guidelines on this.
Totally. Thank you very much, friend, for your experience, all the knowledge that you are sharing, and also your great passion to deliver more information about these topics that I think is very complicated now. But I think many people is very interesting on this. And I just want to close your participation on this last question. Which are your best recommendations now, based on your investigation for people that are facing these kind of transitions? Which are your last consideration or recommendations for them to close this topic?
So for answer to your question, I think that for converting from CPB to an ECMO, in my own experience, no, let's start with the ECMO to CPB. My experience is that never take lightly the heparin resistance part of it, because patients are mostly heparin resistant. And if you are going as a perfusionist or a cardiac surgery unit, you're going on pump, don't take it lightly, because if the ACT is coming as 330, 370, even after giving so many doses, that means there's something wrong. So you need to get the number adequate first before you go on pump from ECMO to pump, because it could be a very devastating kind of situation you will be in. Or and coming from the other side of things, like coming from ECMO to the from the cardiopulmonary bypass to the ECMO, obviously that's obviously, there's no right or wrong, but I think it depends on the patient to patient. If you have to give, I would say, the protamine, the patient is bleeding so much, and they you the bleeding is uncontrollable, and then obviously if you have to give protamine in those situations, then obviously you give slowly, and always depend on your baseline ACT results. So get the ACT results once you are on ECMO. So get the results. Don't rely on the results which were on the pump. So
Okay.
pump may be 480. When you actually go on ECMO, they may be after some time is 380, may have starting to wear out. It's a different temperature as well, while you're fully normothermic. So let's say you come back to 380, you want to give like a small doses to check to that level, rather than just think that, okay, we need to reverse like a cardiopulmonary bypass. No, it's a very different scenario.
Totally. Thank you very much for that last word, friend, and happy honor to have you here.
Thank you so
Sharing
much. Thanks for
for
having
the
me.
community.
I hope it was useful, and I will try my best to speak slowly next time.
Yes, totally. Thank you for the
Thank you. Thank you
report,
so much. Thank you.
and thank
Thanks
you
a lot.
for all for being here. And it will be a pleasure to have you here in this Saturday day. And thank you for all the questions. And
All right.
thank you, Salman, for
Thank you.
your time. See you
Thank you.
soon
Thank you,
on
everyone. Thank you,
other
everyone, for
interesting
coming.
topics.
Nos
All
Thank you.
right.
vemos pronto.
Thanks. Bye-bye.
Bye. Gracias a todos por estar aquí, muchas gracias. Un placer tenerlos aquí, gracias por su interés en estos nuevos tópicos que están saliendo y bueno, los esperamos. Les dejamos en el chat algunos links, ojalá que nos apoyen a compartirlos. Tenemos nuestro canal de YouTube donde podemos publicar todos estos webinars para que ustedes los sigan viendo. Ojalá que sean de su agrado estos tópicos tan interesantes y también tenemos un canal de Telegram que los invitamos cordialmente a unirse. Es un canal destinado justamente a la difusión de todos estos eventos gratuitos que tenemos para todos ustedes. Así que muchas gracias por estar aquí, muchas gracias por sus preguntas a los que participaron y bueno, los vemos en el siguiente webinar, que justamente el siguiente webinar es el próximo 26 de agosto. Así que les recomendamos mucho unirse al canal de Telegram para que puedan ver la información ahí. Y bueno, muchísimas gracias por estar acá a todos los que se unieron.